These perfect scenarios are not helping your students. You're teaching them to follow a cookbook that gets thrown out the second they step out of the classroom and into a real-world chaotic call. The goal of simulation isn't to get 100% on a check sheet. The goal is to forge resilient clinicians who can think critically under pressure, manage ambiguity, and make those hard decisions when resources are low and the call is less than ideal. In our new episode, we're ditching the perfect scenario and talking about how to really prepare for the street.
Attention all units, the air is being held for emergency traffic only.
This is the Pre-Hospital Pulse Podcast, the podcast that delivers high-yield EMS education and real-world opinions you won't find in a textbook. We're here to dissect complex clinical concepts, challenge the dogma, and explore what it really means to think beyond the protocols. Opinions and discussions on the Pre-Hospital Pulse podcast are for informational and educational purposes only. They represent the perspectives of the host and the guest and do not necessarily reflect the official policy or position of any employer, agency, or regulatory body. This podcast is not intended as a substitute for professional medical advice, diagnosis, or treatment. The clinical concepts and debates presented are designed for trained EMS professionals to challenge dogma and explore the why behind the medicine. All listeners are responsible for adhering to their local protocols, scope of practice, and direct medical control. Always exercise your best clinical judgment in the care of your patient. Let's start with a simple question. When you run a scenario in class, is your goal to get 100% perfection on the check sheet? Is it to perfectly follow the cookbook for, say, a CHF or congestive heart failure patient? Pretty much everybody says yes. But what happens on the street when that CHF patient is also diabetic, who also just happens to be septic, and you're working with a brand new partner, and you just used your last CPAP on the previous call? That's the gap. The gap between the perfect scenario and the chaotic, less than ideal reality that we find ourselves operating in. Today, we're going to talk about why the perfect scenario is failing our students and how we can and we must do better. Because out here in the real world, there is no cookbook. This episode is going to be all about simulation and scenario-based training in EMS. Scenarios are where we bridge the gap between our textbook knowledge and our street-level application of that knowledge. It's our single most important building block for making a quality clinician. But there's a bit of a debate. And that debate exists whether we say it out loud or not. Are we just training the students to pass a test, to follow some linear, predictable script? Or are we going to actually forge resilient critical thinking providers who can manage the chaotic environment that they will find themselves in once they leave the classroom? So for those of you who may be educators in some capacity out there, I'm going to give you some ways that you can challenge your students and break them out of that cookbook mindset. For the EMS students or the new clinicians or maybe even the experienced clinicians, I'm going to give you some ideas on how you can take charge of your own training and build some of these skills yourself, even if you don't have access to some super fancy high-tech sim lab. Now let's get into it. Why do we do scenarios? Well, the obvious answer, we need to practice our skills. We need to practice hands-on doing things with a patient. We need to practice team dynamics, right? So the only way to really do that is with some sort of scenario. Where do these scenarios fail? Unfortunately, in the perfect scenario, we have a student who gives drug A, the patient gets better. the student gives drug B and the patient gets worse. Problem with that is it's predictable. Most of our scenarios that we deal with are designed with one specific correct pathway. And this trains students to hunt for the instructor's answer, not to find the best answer for the patient that may be in front of them. In reality, calls are not perfect, calls are not linear, calls often don't have just one answer. Real calls are messy. Information quite frequently is ambiguous. It's incomplete, or it may just be wrong. Patients and families, they lie, they're confused, could be hysterical, maybe they just don't know the information. Unfortunately, most scenarios in the class environment are sterile. You have blood glucose, vital signs, all that stuff is up on the screen. Everything's perfect. Everything fits exactly the type of patient that you're trying to portray. This topic connects back to the core mission of this podcast, that the classroom is controlled, but the real world is not. And if our training is perfectly controlled, we've not prepared that student for anything. So what's the difference between a skill competency and critical decision making? Well, skill competency is just, can you do the skill? Like, can you place an IV appropriately with sterile technique? Absolutely. What about the critical decision making? Well, the critical decision making related to something as simple as an IV is, why am I even starting an IV right now? Should I be starting this IV right now? Where should I place this IV if I have multiple options on locations that are acceptable? Well, let's talk about how we can develop some of those critical decision-making abilities in our student, or if you are the student, how you can work on developing these critical decision-making skills for yourself. Our goal should not be for the student to win. Our goal should be to see the process and to force them to make hard decisions in a stressful environment. How can we do that? Well, here are a few tips. We can inject some real-world things into our scenario. What about resource limitations? Well, 30 minutes from the hospital, you have one 500 ml bag of saline, your monitor battery is only at 20%. How do they react to that? What about distractors? Can definitely add some distractors into our scenarios pretty easily. What about a family member? Can use another student to play that family member. Have that family member screaming, giving bad information, questioning everything that the student is doing, who's running the scenario. Have them ask the student multiple times, why aren't you just going to the hospital? Ambiguity. So the patient is unresponsive. But that unresponsive doesn't have to be a perfect GCS of 3. Maybe they're a GCS of 7-ish. Make the student dig to find out that information. Make the scenario dynamic. The scenario should change based on what the student's actions or inactions are. If the student tunnel vision's on the airway, have the blood pressure drop. If they waste a bunch of time on a non-critical intervention, something deteriorates with the patient. While all of these are useful, we got to make sure that we're creating winnable failures. The patient doesn't have to die, but the student needs to feel the pressure of that potential failure. Sometimes the win is not doing everything correctly. Sometimes the win is recognizing a bad situation and calling for help early. Activating those resources that they may need in a timely manner so that they get to the patient in a timely manner. That's a pretty big critical thinking skill that can pay off quite a lot once they get out of the classroom and into the real world. And we can't just run the scenario. In my opinion, the most important piece of the entire process is doing a quality debrief. And all the learning really happens in the debrief. And don't just tell the student what they did wrong. Ask, why did you make that decision? Find out what their thought process was. And if their thought process is incorrect, this is where we can correct them. Some ideas there. Maybe I saw that you paused before you gave that epinephrine. What was going through your mind? Ask the student what was the hardest decision that they had to make during the scenario. What about for the student or the new provider or even the experienced provider? How can you do some of this on your own and improve your own education and your own abilities outside the classroom and outside of the sim lab? You can't just wait on your instructor to hand you these type of scenarios. You have to be proactive. We can do a lot with a low fidelity, high yield type model. You don't need a $100,000 simulation manikin to practice these skills and to practice real world type scenarios. All you need is a partner in your brain. How do we do this? Well, grab another motivated student or your partner if you're on the rig. Create a 5-minute scenario. One person is the provider and the other person is the controller of the scenario. A little quick rundown of an example here. Our controller tells our provider that they're being dispatched to a 68-year-old male with shortness of breath. Give some more scene details. All right. As the provider starts to run the simulation, they need to be asking, what's my scene safety look like? I'm going to use proper body substance isolation, etc. What's my general impression of the patient? And at this point, the controller is going to follow up with, you're going to walk into the residence, the patient's going to be in a recliner, he's pale, he's diaphoretic, and he can only say a couple words at a time. All right? And your provider should be following that immediately with applying oxygen, making sure that the airway is open, looking for those life threats, getting those initial set of vitals. Now we can throw in a little bit of a curveball. As the provider's doing all that, the wife grabs your arm and says, he's a DNR, here's the form. Now we can pause. What's your next move? What are you thinking? What are the protocols? And what's the right thing to do for the patient? Why does this work? Well, it's rapid fire. You can run 10 of these or so in an hour. It costs exactly $0 to do this. And it focuses on the hardest part, the critical decision making. Well, let's take all of this that we've talked about so far and let's put it together in a simple little call, and we're going to go over this call in 2 different ways. The call is going to be 55-year-old male with chest pain. The first thing we're going to discuss is going through this scenario and how this scenario is often presented in linear fashion in a classroom setting. Dispatched to a 55-year-old male with 10 out of 10 chest pain. Vitals are stable, the patient is calm. Student's going to do a 12 lead. Instructor's going to tell the student that it's clearly a STEMI. There's no curveballs here. The debrief, well, you missed that the patient needed aspirin. While it's important, it's simply just task focused. Now, how can we take this same scenario and turn it into something that's much more valuable to the student? Now we have a 55-year-old male. His chief complaint feels like he has indigestion. Vitals are kind of weird. Got a blood pressure of 90/60, heart rate's 110. Patient's very anxious, and he smells like whiskey. Student decides to do a 12 lead again. What do they find on that 12 lead? Well, it's sinus tach, but there's no clear ST elevation. Now what are you going to do? Curveball here is, while you're trying to decide on what to do about your findings in your initial assessment, you notice that the patient's blood pressure drops to 78 systolic. What happens next? Now in the debrief, why did you hesitate to treat for acute coronary syndrome? What did the smell of whiskey make you think? What was in your differential diagnosis list? When you saw that blood pressure drop, what was your new priority? This debrief and this scenario makes things process focused, not just simple task list focused. The whole point of this is that the critical scenario doesn't have an easy answer. It forces the student to think. It forces them to manage ambiguity. And it forces them to prioritize, just like we're forced to do every single day out in the real world responding to these calls. Let's boil this down into a couple high-yield takeaways for everyone to remember. Stop training for the perfect call. Let's ditch the cookbook. The real world is messy, and your training needs to reflect that. Embrace the chaos in your training. For the educators out there, your job isn't to make students win, it's to make them think. Inject things like resource limitations, ambiguity, real-world stressors into your scenarios, and then follow that up with a great debrief. And the debrief is where the learning happens, so ask why, not just what. And then for the students or the new providers, your education is your responsibility. You don't need a sim lab. All you need is a partner who's willing to practice with you and go through some of these 5-minute verbal scenarios. It'll do way more for your critical thinking than 100 perfect manikin scenarios. All right, that's our episode for this week. If this episode gave you an idea to think differently, do me a little favor, share it with at least one other person. Could be a partner, could be a student, could be an instructor. It's a good way to help our podcast grow and reach more people. If you haven't yet, go ahead and subscribe and leave a review on Spotify or wherever you get your podcast. It makes a large difference. What are you struggling with? What topics do you want to hear debated? Find me on Instagram or TikTok at Pre-Hospital Pulse and let me know. I'm always open to suggestions. Until next time, be safe and do the best you can for your patients. Thank you for listening.